Hello, welcome to today's presentation, Cutting Edge Treatments for Rotator Cuff Tears, presented by Dr. John Costouros, orthopedic surgeon with the Institute for Joint Restoration and Research at Washington Health. Dr. Costouros is a shoulder specialist serving patients in the Bay Area and beyond for over 20 years. Dr. Costouros has excelled in his field by providing the very latest advancements in the diagnosis and treatment of shoulder disorders. He completed his medical school and residency at UC San Francisco and completed his fellowship at Harvard Medical School and University of Zurich, Switzerland. He is board certified with the American Board of Orthopedic Sports Medicine and the American Board of Orthopedic Surgery. Please welcome Dr. Costouros.
Welcome, everyone. It is my pleasure to bring to you the latest and greatest as it comes to rotator cuff tears in 2025. This is Dr. Codman, who is considered the grandfather of shoulder and who is credited with writing the first treatise on the comprehensive treatment of shoulder disorders in 1934. My practice has really been exclusive to shoulder disorders for my entire career, over 20 years. It is a very interesting and complex joint with a variety of pathologies that we treat. I've had the privilege of focusing on this area for a long time, be it clinical practice, clinical research that has been published, journeys around the world to ascertain the newest and greatest techniques, the development of medical devices, performing as a principal investigator in multiple FDA clinical trials, and the list goes on, including the training of various doctors, students, residents, and medical staff from around the world. So it's been a real pleasure. Today we're going to talk primarily about rotator cuff tears, which as a shoulder specialist is the most common condition that I will see in my practice. It is something that affects all of us at some point, for better or for worse, and there are a variety of outstanding treatment options that we have available to us today. My practice also treats patients with sports disorders, from weekend warriors to professional athletes, instability problems such as shoulder dislocations, fractures of the humerus and collarbone, arthritis, and joint replacements, which have gone through a wonderful evolution to this day and are a very common condition. Failed prior surgeries, so revision problems that are sent to me for, unfortunately, patients who may have had well-intended treatment done elsewhere but needs to be revised and reconstructed. And there are a variety of arthroscopic or minimally invasive techniques where we utilize cameras and small devices to perform a myriad of procedures, but sometimes open surgery is still indicated. And here's a picture of me in the operating room on an average day. This in a snapshot are some of the areas that I'm going to focus on today pertaining to rotator cuff tears. And so there is a broad spectrum of things that we can do, beginning with non-invasive conservative measures like injections or physical therapy, which can cure many problems affecting the rotator cuff. And then we get into surgeries, which are depicted here in various photographs, from things like arthroscopic repair, which we see here, to tendon transfers, to sometimes joint replacements are required, and then some newer modalities which have been surfacing over the past couple of years. SCR stands for superior capsular reconstruction, which was a technique developed in Japan and something that I traveled over there to learn more about. And then more recently, balloon placement. So this is subacromial balloon placement, which is a balloon that is placed arthroscopically into the shoulder in some cases of non-repairable rotator cuff tears. And it's been a wonderful intervention more recently. The shoulder is the most complicated joint in the entire body. It has a wide range of motion, more so than hips and knees and many other joints. And because of that, there are a variety of structures which maintain this inherent stability while maintaining range of motion. It's a ball and socket joint, and the ball and socket are enveloped by a series of rotator cuff tendons. And this is what we're going to be focusing on today. There are 4 of them, and they act like a swim cap around the shoulder right here. So these are 4 tendons which come around the upper part of the humerus, which is the arm bone. So going a little bit deeper, we have the capsule of the joint, and so all joints are enveloped in a capsule which contains joint fluid, and this allows for free gliding with joint fluid, which lubricates the surfaces of the bones, which are covered with cartilage. Deep to the capsule and embedded in the capsule are a variety of ligaments, which are depicted here in colors, which act to stabilize the shoulder in various positions of arm elevation and rotation. And this depicts the socket of the shoulder joint, which is called the glenoid. It's a little bit analogous to a golf tee. It's very small. And these structures here, which look pointed, are the labrum. And these enhance the circumference and the depth of the socket to provide for stability, but at the same time, structures that can be torn and injured with dislocations, for example. Rotator cuff tears are the most common condition affecting patients presenting to a shoulder specialist. They affect 50% of the population aged over the age of 60. And I describe rotator cuff tendons as car tires, with more miles, with more age, with more wear and tear. Driving over a pothole, for example, which can puncture a tire, or falling onto your outstretched arm, you can tear the rotator cuff tendon, which can become thin over time. These injuries account for $3 to $5 billion per year in medical costs and decreased productivity. And this is some older data going back about 10 years, so I can only imagine it's going to be greater than that today. Rotator cuff tears impose a significant impact on overall function and quality of life, and they affect, as I said, all of us at one point in time. This is a picture demonstrating, again, the rotator cuff tendons and muscle. Tendons, which are here, attach muscle to bone, and there are 4 of them in the shoulder called the supraspinatus, which is the one over the top, over here. This is the muscle tendon unit that is responsible for elevation of the arm in this position here. Infraspinatus is the one that allows for external rotation, as does teres minor, and subscapularis is the one that allows for strength and internal rotation, like pressing on your belly. The rotator cuff provides strength and elevation, internal rotation, external rotation, and elevation. And if you think about it, it is something that we use all the time, getting ready, doing our hair, brushing our teeth, lifting a glass out of a cabinet, throwing a ball, or swinging a tennis racket, reaching behind our back to put on a belt. It's something that is so common, and so you can imagine with injuries how devastating this can be to all of us. What causes these injuries? Age-related wear and tear, repetitive motion in life, work, and sport, compression and friction on the bone that lives above it, that's called the acromion here, and sometimes as we get older, a bone spur or an outpouching of bone can develop, which can impinge on that tendon and lead to tears or just pain. And sometimes it's not wear and tear over time, but a single fall can do the damage, or a car accident or a dislocation. Some environmental factors that can also lead to rotator cuff disease and tears are things like smoking. Smoking is very bad for rotator cuff tissue and should be avoided for many reasons, including in this case, what it does to the shoulder and the tendons of the shoulder. Rotator cuff injuries are a broad spectrum of disease, beginning with just some intrinsic degeneration within the tendon itself. We talked about impingement, which is bone spurring, which can compress onto the top of the tendon. And so these elements can lead to partial tears of the tendon, or in more severe cases, tearing all the way through, which can look a little bit like this if you're looking with a camera arthroscopically. Rotator cuff tears, unlike other things in the body like a cut or a broken bone which can heal, can never repair themselves. So a partial tear will never reverse itself and become a normal tendon once again. Same holds true for a full thickness tear. Now some people have these tears and they don't even know about it. They have a little dull achiness here and there, occasional pain at night when they sleep, but they go on, and without an MRI, they oftentimes will come to me many years later, and there's evidence of a chronic tear that's been there for a long time. They didn't even know about it. Some patients have mild pain and dysfunction. Some people have excruciating pain and inability to raise the arms at all, even with some of the smallest tears. So that's really the art of rotator cuff disease. It's a broad spectrum. Now, in the setting of full thickness tears, what happens is the muscle and the tendon will continue to degenerate over time. And the process is called fatty infiltration. The muscle is replaced with fat. This is not reversible, and if it gets too far along, the muscle tendon unit cannot be repaired back to where it came from if surgery is to be considered. If it is repaired, this degenerative process can be halted, but we can never reverse it, at least not in this day. Here's an MRI that depicts the process of progression of fatty infiltration over 2 years. And so this is the humerus, this is the glenoid, this is the tear, this white here. This is the tendon that's supposed to be a consistent black bridge all the way and attaching to the bone. So it has torn here. And so this is looking from a different angle at the various rotator cuff muscles. This is the one that is torn, supraspinatus. This is the subscapularis. This one is not torn, but you can see the consistency of what a normal muscle looks like versus this whiteness that is embedded in the muscle itself and around. So this is what fatty infiltration looks like and what it looks like as it progresses. And so even to unskilled, untrained eyes, you can see a difference looking at this circular area here to here, progression. Rotator cuff fatty infiltration is correlated with function, with pain. So patients with more fatty infiltration and larger tears will have worse function, worse pain typically, and it affects the surgical prognosis. And so when I see something like this, that's a clue to me before considering surgery that more likely than not, this is not going to be a repairable rotator cuff tendon tear. This is what it looks like under the microscope. So this is normal muscle, and this is what fatty infiltrated muscle looks like. So you can appreciate all this white stranding that occurs in between the individual sarcomeres or muscle fibers. When we evaluate the shoulder, we first begin with obtaining a history. We then do a physical exam, and then we get onto imaging such as MRI, and then we talk about treatment. And this is me at the IJR seeing a patient back in the days of COVID when we had to wear masks routinely. Rotator cuff impingement presents as pain in the upper arm, which can radiate down to the elbow. It rarely goes past the elbow. If that occurs, it's probably something going on with the pinched nerve in the neck. Worse pain with overhead motion, reaching behind the back or across the body can be typical. Night pain is very common with rotator cuff disease, pain interfering with sleep, weakness overhead, and stiffness doesn't tend to be a big issue, mainly pain. That can be a clue of a different condition affecting the shoulder. What do we do initially? We begin with physical therapy, we then try some anti-inflammatories, and then we begin a trial of injections. Steroid injections are still commonly used and can be very helpful. More recently, there's been a lot of buzz and research on biologic injections, such as platelet-rich plasma, stem cells. I've studied these personally in the laboratory at Stanford and beyond, but we have not seen real consistent results with the use of these biologic agents in the shoulder. So they're not covered with insurance. They are something that patients can receive with private pay, but again, controversial at this point. What we do know is we can have and provide consistent results with surgical treatment if the above measures fail. Now, in the old days, rotator cuff repair was very painful. It was very invasive. We would have big incisions, cut through muscle, and do things like this, which perhaps you've heard about. Patients would say to you, wow, rotator cuff repair surgery is so painful. They may have had open surgery done years ago. Today, what we do is something much less invasive and elegant. We have small incisions, small camera, and we enter the shoulder and we do our work, and this is what the post-operative incisions will look like. Here's a video demonstrating this rotator cuff tear, and this is an older video where we used to use these metal anchors. Most anchors today are not made of metal, they're made of absorbable plastic. And so we place these anchors into the bone where the tendon tore from, and these anchors have sutures attached to them, and then we will take these sutures with these small devices and pass them through the tendon edge, as we will see here, and tie knots over the top of the tendon to complete the repair. And so these are nifty devices, some of which I've developed to allow for passage of these sutures through the tendon and tie it back down to the anchor. So arthroscopic repair today is an outpatient procedure that takes about 40 minutes in my hands. And in addition to the rotator cuff, we also have the ability to address other causes of pain in the shoulder. Results are excellent and time tested. Typically, patients are immobilized in a sling for about 4 to 6 weeks, and the physical therapy is a critical element to obtaining a good result. It ends up taking about 3 to 6 months at the end of the day following rotator cuff repair to fully recover. But sometimes these tears are not repairable, as I mentioned earlier. And so we have some salvage options, which I've written about in these chapters, that can be considered. Sometimes just a cleanup, which is debridement, is helpful to remove inflammatory mediators. One of the biceps tendons resides in the shoulder joint, and this can be a source of pain. Sometimes just partially repairing the tendon is helpful. Other times we consider some more aggressive options like tendon transfers and superior capsular reconstruction, which was the technique from Japan that I will focus on. And what that procedure does is we take a graft of tissue, either from a patient's own body like the thigh or from a cadaver, and we will place this as a buttress over the top of the shoulder joint where the tendon is torn to create some added stability and improve efficiency of the other tendons which have not torn. There are other patches and grafts which are available. Some are cadaver, some come from animal tissue, some are synthetic. These can also be helpful. More recently, and I'll talk more about this, the balloon has been a very interesting and positive intervention and has helped many patients in my practice since its FDA approval. And then finally, reverse shoulder replacement, which is a special kind of shoulder replacement used in patients who have irreparable rotator cuff tears. This is a drawing demonstrating the lat muscle, which we can release from the upper arm and then recreate the irreparable rotator cuff tear, which is this part here, but by slinging this tendon over the top of the shoulder and retraining that muscle to act as an elevator rather than its native function, this can be something that can be very helpful. And this is what a latissimus muscle tendon looks like during open surgery. It's a big procedure with a lengthy recovery, and it has fallen a little bit out of favor now that we have other treatments available that are less invasive. Here is a video.
Okay, Larry, can you tell me how much motion you had with your right arm before surgery?
Approximately this much here.
Okay, and go ahead and show me what your range of motion reaching forward is now. Good. Now come on down for me. And can you turn to the side and do the same thing for me? Raise your arm up. Good.
So this is a patient who had latissimus dorsi transfer. This is a patient of mine from approximately 2004. And so in those days, we had not the balloon, not the matrices, so we had other options such as this, but it took a long time for this bricklayer, as it turns out, who came to me late with an irreparable tear to undergo latissimus dorsi transfer. More recently, arthroscopic superior capsular reconstruction was a technique that I learned about in Japan when I was an invited American Orthopedic Association fellow and professor there. In Japan, they did not have reverse arthroplasty, and they're not allowed to use cadaver tissue. So this is a piece of tissue from the thigh that they would take and do this procedure with over the shoulder, which I spoke about earlier. It is something that is available for patients who have some irreparable rotator cuff tears in the absence of significant arthritis. And so this is the graft that we tunnel in through the outside, through these little portals that we use arthroscopically, and sew it down over the top of the shoulder to provide for excellent results, as we see in this patient. Now, in 2021, I was one of the first surgeons in the United States to use this technology, which was developed in Israel, and had several years of good results over there until the FDA allowed us to implant it in our American population. It is an excellent option for some non-repairable rotator cuff tears affecting supraspinatus and infraspinatus. The rotator cuff tendon in the front, the subscapularis, needs to be intact for this to work, and patients have to have minimal arthritis. The balloon is resorbed over about a year, and it's all done minimally invasively. And this is what it looks like. What happens with a rotator cuff deficient shoulder? There's force imbalance, there's upward migration of the humerus, and over time arthritis can develop. So here's a patient who had the balloon placement done a year ago. Okay, Raymond, you're 1 year following subacromial balloon placement for an irreparable massive rotator cuff tear on the right side. How are you feeling?
I feel wonderful, thank you, Doc.
Do you have any pain?
None.
What's your function like?
I think my function is full function after a year.
Excellent. Can you show me how far you can raise the arm up overhead?
Okay, absolutely.
And then come on down, and then turn to the side, and do the same thing for me. Perfect. Come back down and face me once again. So those are some very dramatic results after balloon placement, and these patients recover very, very quickly. But sometimes when patients have arthritis or more complex conditions, we have to move to a prosthesis. And these are various types of replacements that we use today. These three here require a functioning rotator cuff to work. This one, which is called the reverse, which is something that I was one of the first to bring to the United States from Europe in 2004, is widely used today for patients who have irreparable rotator cuff tears with arthritis or other deformities or bone loss. And the way it works is really remarkable. It was developed by a French engineer named Paul Gramont. It is a wonderful increase of the lever arm of the shoulder by changing the center of rotation of the normal shoulder, which is here. It distalizes and medializes center of rotation so that the deltoid muscle, which substitutes to elevate the arm, has a mechanical advantage. So think of a longer stick prying something up versus a shorter stick. That's the way this works. This is a patient of mine who they featured in the front page of the San Francisco Chronicle back in 2010, who had both of his shoulders replaced, and it just demonstrated how wonderful this technology was. And although less shoulder replacements are being done compared to hip and knee replacements, it continues to be the fastest growing segment of the joint replacement market. Here's a patient of mine from 2005 who had 2 failed prior rotator cuff repair surgeries before they came to me, a lot of arthritis. And I saw this patient 20 years following surgery recently, doing remarkably well with no pain, excellent restoration of function overhead, and very, very happy. The devices were different 20 years ago, but they still seem to work quite well. And this is his function. What about today? We are seeing further improvements in implant design. We have software today to allow us to virtually plan surgery before we even get to the operating room, and that allows for improved precision. We have intraoperative guides, which we can use to help us precisely place our preparation tools. Most surgery replacing the shoulder today is outpatient. And over here at Washington, we are one of the first centers in the US as an FDA trial of a stemless reverse, which is now FDA approved. So this is bone preserving. And we found accelerated recovery in patients undergoing this. And furthermore, I'm going to be one of the first centers here west of the Mayo Clinic, which was the first recently to perform robotic-assisted shoulder replacement surgery. So the robots are coming even to the West Coast. And then finally, virtual reality planning. And so this is a fellow of mine that I train at Stanford who is virtually performing surgery using these goggles and these devices just to practice before coming to observe me in surgery. So amazing, amazing technological developments. What do we see in the future? Augmented and virtual reality, as I depicted before, robotic assistance. I don't think the shoulder surgeons are going to go away completely, but I think steps of the operation will be enhanced with robotic assistance. We talked about tissue engineering, growth factors and stem cells, which are still being investigated, and more recently, the advent and the influx of artificial intelligence into our clinical practice. So in conclusion, most rotator cuff tears today can be repaired by conventional arthroscopic methods and yield excellent and durable outcomes. We talked about some of the salvage procedures, tendon transfers, superior capsule reconstruction, balloon placement. These are here and work well in select patients, but patient selection is everything. The future of rotator cuff repair, in my opinion, lies in the enhancement of biological healing. and there will come a day when things like prosthetic replacement may not be required. Thank you for your attention.
Thank you. We do have a couple of questions. The first question is, what is the most common cause of rotator cuff tears?
Well, as I mentioned earlier, the most common cause of rotator cuff tears is just age-related degeneration over time. So every time we raise the arm, we rotate, we lift, we sleep on our arms sometimes, that can lead to attritional changes in the tendon. Those can be accelerated with things like tobacco and environmental factors, which can cause tendon disease. So that's probably the most common, aside from trauma and repetitive micro-trauma over time.
Okay, and our next question is, are there exercises that will help reduce the risk of shoulder injury?
That's a very good question. And so maintaining homeostasis of the rotator cuff through exercise is very important. There needs to be a balance. And so, much of what we do with day-to-day life is good exercise, but augmenting that with resistance training, so band work, we call that rotator cuff strengthening. So for example, having one's elbow at the side with their arm bent at the elbow, band attached to a doorknob or a stationary object, and you can rotate your arm out with resistance. You can do the same thing with the band on the other side. There's also what we call scapular stabilization procedures, so pulling the shoulder blades back with resistance and holding it. Some of these exercises you can easily obtain online, and then the resistance bands are something that you can obtain over the internet, easy for purchase or at your local drugstore. Sometimes it's helpful to have a visit with a skilled and trained physical therapist just to make sure that the exercises are done correctly, and then a home program can be taken from there.
Okay, and our last question, if I have consistent shoulder pain, where should I start to seek treatment?
Well, if you have consistent shoulder pain, it's always, I think, most effective to see a specialist that can get to the nitty-gritty right away. We also work very closely with physical therapists, primary care doctors, and people of other specialties who will refer patients to us frequently. But as I said, with something like a rotator cuff tear, it's not something you want to ignore for a long time if it's torn all the way through. So the better part of valor, in my opinion, is to see a specialist, such as myself, and get to the diagnosis so that the appropriate treatment can be obtained and hopefully cured.
Great. Well, thank you, Dr. Costouros, for this insightful presentation. And this does conclude our program. Thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.